Thank you all so much for coming. We're very excited to present our second event. I'm going to take this down so everyone can hear me clearly. Our second event is everything you need to know about fibroids. We launched the Fibroid Center back in June, so it's a relatively new center of care at NYU. And this is our second event this year. So our next event actually will be at the end of February at our new space, which is East 53rd Street. And we can tell you all about that if anyone's interested. Okay, and this is meant to be interactive and fun. And so it's really meant to answer your questions and think about the best ways to manage fibroids. So I want to introduce our panelists. I'm Taraneh Shirazian. First one listed here. And this is Dr. Eswar, Chris Eswar. He's our Associate Director for the Center. We have Dr. Chan, who's one of our newest members, and actually she will be heading up a new site in Brooklyn soon, so we hope to have a presence in Brooklyn in the next few months. Holly Gorman, sitting right here, she's our fabulous NP, and she actually does all of the intake for the Fibroid Center, so we group this as scheduling a televisit first, where we talk about your goals and objectives and life goals, and Holly does all of those televisits. Dr. Kossel, who's sitting right here to my right, and Shok Mansur, our dietitian, because we do have a lifestyle nutrition program as part of the Center for Fibroid Care. So what are fibroids? I know you guys are all asking. Actually, I know everyone probably already did their research, but this is just a recap. Uterine fibroids are non-cancerous growths, so that's the most important thing. They are not cancer, but as we all know, they create lots of issues for women, for patients with uteri. And these growths can become quite large and create lots and lots of different symptoms that we will discuss. They usually appear during childbearing. There's a very, very small risk of cancer, I should say. It's 0.3% is roughly the risk of a leiomyosarcoma. So that's why we say that they're largely non-cancerous. And as you can see in this picture here, the fibroids can vary in size, they can vary in number, they can be throughout the uterus, and again, can create a lot of very disturbing and disruptive symptoms. So what are the causes? We don't really know the causes of fibroids, but we do think it's a mix between genetics, which, there is a hereditary component to fibroids, and potentially environment or diet. The data on that is very limited. We don't actually know, but we do think that the causes are multifactorial. Increased levels of estrogen and progesterone may be linked to fibroid growth. So what stimulates fibroids? Everyone always asks, well, why are they getting bigger? Well, they're being fed by estrogen. So it could be something in the diet. It could be extra estrogen that we're taking. There are things that can stimulate growth, even though that's only a part of the picture. These are some of the risk factors that we list, and I think many of you may have heard of some of these, like the family history, the red meats, et cetera. Excess weight or obesity can also stimulate them. So there are some risk factors that we know of. And so many people have symptoms, but actually the majority of fibroids are asymptomatic. So a lot of people don't even know they have fibroids because they don't have any symptoms from them. If you have symptoms, some of the most common symptoms are things like pressure, urinary frequency, bleeding, painful sex, vaginal pressure, bloating, weight gain. During COVID, I can't even tell you how many patients I saw who just thought they were gaining weight from COVID, when in fact it was the fibroids growing. So I think a lot of times we dismiss kind of weight gain and bloating as being normal or being something, that we've done, but in fact it could be the fibroids. So that's an important symptom. There is a racial disparity in terms of fibroid disease. And we see it in the evidence and in the literature. Fibroids are more common among symptomatic Black women than white women. And so we know that there's a racial disparity there. I think there is a lack of public awareness about fibroids and its potential impacts, which is why we have a Center for Fibroid Care. We really want to be a place like a home where patients can come and receive not only education and information, they can receive treatments and lifestyle choices where we are comprehensive and offer all things. And so this disparity is important because many Black women don't get timely care, and access to care is an issue. And there's data that, in general with racial disparity, sometimes patients wait 3 years or longer for care that they should be getting. So again, it's about raising awareness and spreading the word. I think I mentioned this already, but our mission is to make sure that patients are heard, that we address your concerns, that we talk about options, that we offer all options, and really that we work together to build a center of excellence that provides you with everything you need. And there obviously is lots of value in that. So one thing I do want to say, and I think I get to this a little later, is that we also are very invested in looking at research. What are these factors that contribute to fibroid growth? What are the things we can modify? I'm very interested in modifiable risk factors. And I know Heather and I have talked a lot about it. We can talk a little about it at the Q&A, but what can we modify in what we're exposed to in our environment that could potentially help us prevent recurrence? Because not only are fibroids really common, but recurrence of fibroids is very common. So it becomes a lifelong issue. This is our team, which I think I pretty much introduced everyone. We have a number of surgeons. The only person that's not here today is our interventional radiologist, because we do offer uterine artery embolization here at NYU as well. So that is also a choice, which we can discuss. But in addition to our team, we have the broader team of REI, which are reproductive endocrinologists. We have OBs, we have high-risk OBs. So we have a care team that can take care of you no matter where you are in your life journey. Right now we're here at the Center for Women's Health, but we'll be moving to East 53rd Street, and the Fibroid Center will be housed there. It's a new state-of-the-art center. We're very excited about it, and we think it's just going to be great for care. Okay, so this is a table that lists a number of different fibroid care options. And so maybe I'll mention this, and then I'll ask if there are any sort of questions so far about what we talked about. So there are obviously categories within lifestyle change that we think about, like diet, nutrition, environment, supplements. These are this is like the $1 million questions, If I could put my money on one set of questions, it would be these, Because if we could figure out what combination of things in the environment contribute, we could change them. And I think everyone's very interested in learning that and knowing that. There's medical management, so we offer a number of different medical therapies or daily medical options for fibroids. These are just broad categories. There are procedures, and we'll get into a little more discussion about this as we go. Things like Sonata, endometrial ablation, and uterine artery embolization. There's types of surgeries, which range from very minimal to kind of more major, open to laparoscopic and robotic. So we have all types of surgeries. We have our consulting teams, and we have a lot of different blood work that we do also to monitor fibroids. I'm going to so let me pause for a second. Are there any questions so far? And I'll talk about some of the other nuances. No? Okay, I'll keep going then. So the LIFE program is a research project study where we're looking at lifestyle, nutrition, and supplements and how they can potentially impact recurrence of fibroids in patients who have had a procedure or surgery. So we enroll patients after the procedure or surgery, and we offer them this program, which is a program that we developed Shokir and I and a few other members of the team kind of put together everything from the literature that we have that looks at nutrition, what diets are good for fibroids, what sorts of supplements are good for fibroids, like vitamin D, for example, has data. And we put that combination of things into one program that we offer patients who are interested. And we are currently gathering data on this program. So for those who qualify, who've had a procedure, they can enroll. We think that nutrition is potentially a modifiable risk factor, so that's why focusing on it and thinking about how to change it could really impact, we hope, recurrence. Exercise, same thing. So we hope to enroll more patients and have that data available in the next year or so and be able to understand a bit more about diet and nutrition and fibroids. So these are some of the options. Again, this diagram or schematic is from Sonata, but it does a really great job of showing like the least invasive procedures to the most invasive procedures. And these will be the whole category of things that we talk about today. I think I kind of spoke about this, but we have some newer medications like Myfembry and Orion that are what we call GnRH agonists that drop the hormones that feed the fibroids and can help with bleeding and shrinkage. So there are some newer medications on the market that can be impactful. We have Sonata, which is a transcervical fibroid ablation procedure, which is kind of one of our newest procedures that I think has caught the attention of many, many patients, and we get lots of patients coming in for this. It is very targeted. It targets and ablates fibroids, and it's not sort of a global therapy, but it's sort of very targeted for symptomatic fibroids. And I have an animation actually here. Oh, can we press play on that? On the diagram, there's a, yeah. This is really a fun schematic, so you get a sense of exactly how it works. The device is inserted. It has a window that sits flush with the fibroid. Through that, a probe is placed into the center of the fibroid, actually after it's visualized and assessed. It has a zone where you know that the red zone is the treatment zone and the green zone is the zone of radiofrequency dispersion. So you want to keep it sort of within that red zone. And then through the device, there are prongs. And these noises are actually the device showing you how it's inserted and that it's correctly placed. And then it ablates the center of the fibroid. And then the fibroid will shrink over the next 8 to 12 weeks. And so there are, best candidates for this procedure, just like anything. But I think that, the procedure is really great if you have a few fibroids, if you have fibroids under 6 centimeters, if you have heavy bleeding. So it is something that many patients are a candidate for. And we can talk about it in more detail. I'm giving you guys a broad overview of all our choices. Another relatively popular procedure is the uterine artery embolization procedure, which is a more global procedure that drops the blood flow to the uterus to treat your fibroids. And they do try and target individual fibroids, but it's sort of more global or general than, for example, the Sonata, which is a bit more targeted. But it may be a good choice if you have a very big fibroid uterus, if you want to avoid a surgery, if you want a more minimal procedure, if you have heavy bleeding. And sometimes we use this in conjunction with other things, like we might do that and then do another procedure to improve sort of the surgical outcome. Hysteroscopic myomectomy is when we use a small camera that gets inserted that can remove fibroids that are within the cavity of the uterus, submucosal. These are some pictures of that. This is actually looking in with the hysteroscope into the uterus, into the cavity of the uterus, and this is a fibroid in the center of the cavity. So through that camera, we can remove that fibroid. Robotic myomectomy, which I think many of the panelists will also talk about. This is a very popular way to remove fibroids. It is laparoscopic. It goes in abdominally, and a robot is used, and fibroids can be removed completely. It's minimally invasive, same-day surgery, good recovery. So we really think about this when you have, larger fibroids, more fibroids, and when you also may want to preserve fertility for the future. Laparoscopic hysterectomy is a good choice if you want definitive surgery. You never want bleeding. You never want the fibroids to come back. Childbearing is not an issue. You're not interested in that. You can take the uterus. You can leave the ovaries. So the big point I like to make with this is a laparoscopic hysterectomy is not your mother's hysterectomy. It does not equal menopause. It does not mean that everything is removed from the pelvis. You can maintain ovarian function. You can choose to remove the cervix or leave the cervix. And again, another point we can talk about. It's a same-day surgery, and it has a minimal recovery. So I don't think that anybody should be afraid of any option. I think the important thing is to have a discussion with your doctor. So maybe I'll pause for a second since I've talked a lot. Does anyone have any questions about the procedures? Any procedure that caught their eye that they want to know more about, for example?
I just have a question because I've had fibroids, and I'm a carrier of 3 fibroids, thank you very much. And what I found is when I had my fibroids supposedly removed, it was actually some sand to stop the bleeding. So I'm feeling like I'm a little bit out of sorts when I see that, and I still have residual, so I don't know if with these new, functions and medical ways of doing stuff, what I have residually, if obviously it may be calcified, would that still help to remove whatever I have left? Am I making myself clear?
Well, maybe I'm going to have one of the panelists answer, but maybe if you tell us what you mean by sand. Do you mean you had a UAE or?
Yeah, something to that effect up in Mars. This is a while back. So, something about sand, and then it stopped the bleeding, and then I don't really know. I don't believe that I have enough shrinkage, because I can feel a little bit of, you're saying to me shrinkage, which means like it's going to go, and you're not going to feel it.
Yeah. Well, that's a good question. Let's take the first part. Sure. Who wants to talk about UAE?
I can talk about UAE.
Okay, go for it. Take down your mask.
Oh, sure.
Just through.
So, uterine artery embolization. I'm not sure if that's something that you had without going into it. So what they do, the interventional radiologists inject particles that kind of target the arteries that feed your entire uterus. And as a result of that, those particles kind of decrease the blood supply to your uterus over a course of time, with the goal to decrease bleeding and also kind of what we call bulk symptoms, meaning like feeling that pelvic pressure, that urinary frequency, that change in bowel movements, all of those symptoms. And usually embolization is pretty good at kind of relieving those symptoms, but depending on when that's done and where you are in terms of age, and us knowing that average age of menopause is 51, that can be a long time. So if you have like a 10-year span or a 15-year span between that procedure and then hitting your natural menopause, then potentially your symptoms can come back. And as long as you're having regular menstrual cycles and you're having that fluctuation in the hormones that are coming out of the ovaries, that fluctuation in estrogen every month, your fibroids can potentially continue to grow. So really we know that Dr. Shirazian said one of the drivers for fibroid growth is estrogen. As long as you're having those, some of the symptoms, even after having an embolization, can come back. Yeah.
Yeah, so I'm thinking it was a UAE.
Yes.
And what's the success of a UAE, Dr. Castle?
So, I usually quote 70% in the sense that you're going to be left with at least 30% of patients that would be unsatisfied or not fully satisfied with the results, that they would go on to look at other procedures in the future. And I think an important point too, when we kind of talk about shrinkage of any of the fibroids, it's going to be, I think one of your slides kind of goes through this, but everything is dependent on fibroid size, location, and number. So like everything we've kind of went through, there's going to be certain people who are better candidates for certain types of procedure and are going to get more out of it. A lot of times when I counsel patients who are thinking a little bit about uterine artery embolization, if they have a huge fibroid, like let's say they have a big 15 centimeter fibroid, it's going to shrink down, but it's not going to go away. So 15 centimeters, might drop down close to 10, maybe let's say in a hopeful fashion, but then you're still stuck with a 10 centimeter mass. So if just to remind patients that kind of considering that that it's shrinking, but it's not going away completely. So depending on size and the significance of the symptoms you're having, that may make you feel more inclined to remove the fibroid versus shrink it.
I think that's a huge point right there, because so many patients think that UAE will just sort of take away all their symptoms. And the thing about the procedures is there's a range of success. So Dr. Kossel's generous with 70%. I mean, I probably would have put it a little lower. I just think there's a range, right? For some patients, it works really, really well, and yes, maybe 70%. For others, it's like, it could be low. It could be 20%, 30%, So if you have a huge fibroid uterus, you don't really want 20 to 30%. But I think going in, you need to understand related to that there's a range, and you may not get enough shrinkage, as Dr. Kossel said. So I think that's key. And I'm not sure that's well understood out there. I think a lot of people think it just sort of takes care of it. Yeah.
Well, that depends on your healthcare provider. Who's gonna be
Right, it depends on the counseling, 100%, 100%. Yes, and it also is just important in how we talk about it, right? Even to each other. So after you did that, sorry, now I'm going back to your story. So then you did the UAE, and then now you still have symptoms.
Well, it's kind of odd. I feel there's symptoms, but I'm perimenopause, so I wound up going to Dr. Gorman.
Yes.
And it was something strange that happened. It felt like I had that whole symptom back again.
Got it.
And it was like a hit parade, like, hey, let's do this, and I'm like, what's going on with my body? Because I'm trying to understand as I'm moving forward. I'm 57, so I just last year kind of started that whole wave of, perimenopause.
Yeah.
And it took me forever. My doctor was like, good for you, you're good. And I'm like, no, I want to get over this. But for me particularly, I was scared because my mom had ovarian cancer, and I'm kind of like relating what the heck is going on in my whole area.
Got
and
it.
I was like, I gotta make sure I cover myself, So she did something on me. I don't know. She checked something. It's a long story, but anyway.
Yeah. Okay.
It was invasive.
Okay, got it. Okay.
She took me out of the scare.
Good. Perfect. Well, but you brought up another really good point. So what about cancer risk related to these surgeries and procedures, Dr. Eswar? What can we reliably tell people about cancer risk?
Sure. So for all patients with uterine fibroids, we always want to sample the lining of the uterus, especially if you have abnormal uterine bleeding, so heavy uterine bleeding, in any patient above age 45. Another thing we do at the Fibroid Center is an MRI of the pelvis, and so that's going to help us delineate whether you have risk for leiomyosarcoma. It's that rare cancer that can look like a fibroid. So things we look for are patients that have rapidly growing fibroids. So over a short period of time, fibroids go from say 3 centimeters to double or even triple in size over 3 to 6 months. That's very, very ominous. That's something we always look for. But here at NYU, we have a really good radiology department who we have not missed the leiomyosarcoma on MRI. So they're very, very accurate. And so when we're counseling patients regarding risk for that cancer, we can kind of say, okay, with confidence that we can do a myomectomy rather than say, if there was a cancer risk, we'd offer you to go to the oncologist for an open hysterectomy, taking out the whole uterus intact. Because anytime you're doing a myomectomy where you're opening the cavity of the uterus, you're potentially spreading cancer. So in your case, we would be looking to make sure that that's not a risk factor for us. But we have different options to remove fibroids via small incisions, and that can be through a mini lab, making a smaller incision larger, even using something called a tissue power morcellator, that's an option, or placing fibroids into a bag and cutting it by hand. So lots of different options to remove fibroids, but keeping your incisions smaller depending on where your fibroids are located. Yeah, please.
You put it in a bag, is that to avoid any spread or anything?
Correct. That's to avoid. So if you have any risk of that cancer, and say someone that's say 32 years old that has 5% chance of having that cancer, we'd place the fibroid, and they want to maintain their uterus. We can place that fibroid into a bag, pull that bag up through the surface of one of the incisions, and then basically cut it up inside the bag.
I have a wonderful visual of that.
I know, sorry, but that's how we do it. Yeah.
Well, now you
Yeah.
see why I didn't include a lot of like other animated videos.
Yeah, no, it can get
because,
very graphic.
I was like, people get queasy with real live, right? Uteri. Anything else with cancer risk? And one other thing that I'm like, it's
Go
like
ahead.
just what I'm thinking.
Yeah, just go for it.
What about like hysterectomy and cancer risk?
So for hysterectomy and cancer risk, I'm not really.
Just reducing.
Oh yeah, sorry. Yeah, of course. Sorry. Yeah, I mean, the hysterectomy, if you say you're worried about, especially in your case where you have a family history of ovarian cancer, depending on your case, you could offer risk-reducing surgery like hysterectomy with taking out your total uterus. And in some cases, especially if you're over age 50, that's the new data is any age before 50, you can actually remove your ovaries without having any big effect on your long-term survivability. That number has changed from age 65. We used to maintain someone's ovaries up until age 65 because we thought that it would decrease having osteoporosis or older age and providing better cardiovascular health. However, an article came out this year refuting that. But depending on the patient's desires, we can reduce your risk for say endometrial and uterine cancer by removing the uterus. And then if you had some risk for ovarian cancer, then we would take out the ovaries and fallopian tubes as well. Absolutely.
Okay. All right, very good. So are there any other, yep.
Yeah.
So endometrial
Yes.
different than UAE?
Yes.
And we didn't talk about
You're right. We didn't talk about that one in a lot of detail.
not popular?
No, it's popular. There's just so much to talk about, but I'm glad you brought it up. So an endometrial ablation. I'll let one of you guys talk about it. Yeah.
So yeah, it's an interesting point. So I think what I talk about with my patients sometimes is that the fibroid itself is not bleeding, but what it is doing is it's interfering with the function of the uterus. So when it comes time, for the lining of your uterus, your endometrium, to kind of shed as part of your cycle, our uterus is supposed to be a big muscle, and basically it's supposed to be able to contract and close off all the blood vessels and get our bleeding to stop. If you have a big baseball kind of stuck inside your uterus, it's not going to be able to do its job in terms of contracting those muscles down. And the fibroid probably has, we think, some chemical impacts on the lining of the uterus as well in terms of causing heavy bleeding. So that's just the background of where the bleeding's coming from. So that's kind of why endometrial ablation is a little trickier. What endometrial ablation as a procedure is doing is it's basically done through the vagina. Similar to the hysteroscopy that was shown up here, we go into the uterine cavity. We usually do hysteroscopy, take a look around. If there's anything to resect or remove, we do that. And then basically the goal of the procedure, there's many different tools to do it, is to basically ablate or burn or kind of shave away the whole lining of the uterus. The hope by doing that would be that if you kind of go deep enough, that new lining will not grow back. So the goal of those procedures is generally no more periods. Patients actually achieving that goal, the rate is pretty low. Most patients will go on to have some bleeding. There are patients who are satisfied with the level of reduction of bleeding. But the tricky part is we're not really doing anything in terms of actually removing fibroids. And so if you're having those bulk symptoms like we've been discussing, it's not really going to target any of those symptoms because you're still left with the masses. And in terms of how much it will target the bleeding symptoms, that's very kind of patient dependent, again, based off of fibroid size, number, location, and things like that. And then just even in perfect candidates, we know the ablation is kind of not perfect in terms of total cessation of bleeding forever.
So just to clarify, that fibroid that's still there, so this option doesn't do anything to shrink it?
No.
So it's just hanging out there?
Yeah.
Well, it has to be resected first for most third-generation ablative techniques. So meaning we have to go in with the camera, remove the fibroid first, and then we could do something like a NovaSure thermal ablation, which is sort of this thermal one where it's a fan that sits in the cavity of the uterus and burns down to the first 1 centimeter of lining. There's lots of ablation devices, and actually even more every day because I've learned of like 2 new ones now. So it is a very kind of hot category of products right now. I personally feel like the best candidates for ablations are the women who are perimenopausal, who have crazy bleeding. So the way I like to use it is biopsy first, because we want to rule out a cancer. So biopsy and then ablate, because I've seen them transition then through menopause. Like then they may not need anything else. It lasts, let's say, for 3 to 5 years. And I've seen many of my patients sort of transition through that way without crazy bleeding. But that's how I use it. I'm sure everyone uses it a little differently. But
Agreed.
anything else on ablation? Do you guys use other ablative techniques?
Other than the NovaSure, I do like an endometrial resection. So that's similar, like do a hysteroscopy, and then instead of doing a global burn under direct visualization, you use kind of a different tool to resect the lining, and really the goal is to get the entire endometrium so that that tissue doesn't kind of grow back and cause more bleeding in the future. Yeah.
Yeah, when you say resect, is that like you're detaching it or something? Or you're cutting something? Is that what you mean?
Yeah, so everything is done through the vagina, so we're looking into the inner lining of the uterus. And what I mean by resect is that we're using something to really just cut out the endometrium. Yeah.
And obviously, since we're talking about, we're cutting out the endometrium, this wouldn't be a procedure we'd be doing for a very young patient who's looking, to get pregnant. The goal is that we're trying to get it to the level of the muscle so that hopefully no endometrium grows back again. And I would say probably one patient where we would maybe want to look at avoiding ablation would be somebody with significant adenomyosis of the uterus, just slightly higher rates of kind of failing the endometrial ablation in terms of continued heavy bleeding.
And I also recommend for someone who's had a tubal ligation, I wouldn't recommend that either. You can also get post-tubal ablation syndrome where some of the lining continues to basically bleed. And so normally the blood would come out through the cervix and come out like a period. That if you do the ablation well, the area by the cervix won't actually it'd be scarred. And so that blood will kind of come back towards the fallopian tubes and it'll build pressure and pain. So it's another reason to not do an ablation technique on a patient who's had a tubal ligation.
Okay, should we go on? And then we can, I think you have one more, right? But we'll
Don't mind me.
no, we're
That's
going to
fine.
answer it. We're going to answer. We're not going to forget about it. Okay, so this is, so we have this expedited patient care pathway at the Center for Fibroid Care. It really starts prior to your visit. So we want to collect actually a quality of life questionnaire, because one of our big goals, again, is to collect data, to understand your needs, to understand your life goals. So even before you come to see us through Epic, we like to push out a questionnaire and a life goals survey. And we like you to complete those and send those back to us so we know exactly sort of what you're looking for, what you need, and you can tell us in your own words what you've tried before, what has worked or has not worked. And so that's completed on my chart. And then that comes actually to us, either to me or to Holly, usually to Holly. She does the initial intake on a televisit with you. And kind of goes through the questionnaire, your needs, your life goals, those things, basically why you're there for the visit, so that we can better understand what your needs are even before you come in to see us. So that's actually a very important part of all of this, because we like to know what you need even, to start to think of a plan even before you come for that first visit. So then when you meet with the surgeon, which could be any one of us, and there are a few other people in the center, so there's even a few other people. It could be we discuss the options and solidify the best individualized plan for you, and we come up with like an individual treatment goal, basically, for you. So together, we kind of decide which of the things you want to try, what sounds the best, what's going to meet your needs, what's going to sort of solve the issue, and then we arrange to do that. Now we have, and Dr. Ko is not here today, but we actually have an active surveillance arm to the Fibroid Center. And it's for patients who don't want to do anything right now. They just want to be part of the center to monitor. That's perfectly fine. We want to be your fibroid home, as I said before. So if you decide you heard all the options, but you don't want to do anything right now, you just want to monitor the fibroids, we also do that. We call that our active surveillance group. And we'll monitor you every 6 months. We offer nutrition counseling if you're interested in that, with Shok here, who's wonderful. And we just kind of continue to follow. We see what's happening with the fibroids. So if you have small fibroids, I will actually refer a lot of patients to this. You know, if your fibroids are 1 or 2 centimeters, I usually will tell you to do nothing. You know, and sometimes we do get those patients who have really tiny ones. They were found on an ultrasound, and they really don't need to do anything. They can just monitor. So that is also a choice. We refer you to our specialists if that's what you need, if you really want to get pregnant, if you want to see a reproductive endocrinologist, if you want to do IVF, if you want to see our interventional radiologist for UAE, we coordinate all of that for you. And essentially, we also provide ongoing care for you through the center. So these are some of the important elements to us as a fibroid center. We really want people to feel like, you know, their needs are met. And so that is what I have. So I have questions. Okay, cool. These are my own questions. But first, do you guys have any questions? These are the posed questions in case no one comes up with any questions. And these are actually questions I get asked like almost every day. But let's hear if you guys have any other questions. Yes?
Can you explain the difference between assessor and sonata?
Yes. Dr.
Sure.
Swart?
So both of them are called radiofrequency ablative techniques. Assessa is done through a laparoscope. So instead of placing the scope in through the cervix like you would for the sonata, this is done with a laparoscope. You would distend the abdomen with CO2 gas, just like you would any other conventional laparoscopy, and then you place the probe. Instead of they're using ultrasound guidance, they're also doing ultrasound guidance, but you can actually see the probe going into the fibroid itself. So both are still using ultrasound to guide, especially deeper into the uterus, but one is done with incisions, like through laparoscopic surgery, and the other one is done transcervically. Both are equal in their effectiveness.
I think, you know, really the difference is where are your fibroids, you know, are they, so going back to that first picture, maybe I should bring that up again. If the fibroids are, if they're like on the outside like this, for example, you might best approach them abdominally, laparoscopically, robotically, right? But if they are like that hysteroscopy picture, if they're in that inner cavity or they're in the muscle layer next to the cavity, you'll best approach them. These or these, oh, that's subserosal, but intramural or this, you know, you'll best approach them vaginally through a sonata. So sometimes the determination of how to ablate them, it actually depends on the position. We actually don't do Assessa at NYU. There just wasn't enough interest in it. So currently we don't offer it at NYU. But there are some other institutions in the city that do offer it. We do offer Sonata, and we've been doing that since last year. So we do have, as a group, also a wealth of experience with the Sonata technology at this point, because it's the one that more people favored when we were trialing the devices. And there were some reports of some injury with the Acessa that kind of came out, and so I think a lot of providers felt disinclined to try that one. So that's essentially what happened.
Can you
Yeah.
explain, so on this diagram,
Yeah.
there's been a lot about the location of the fibroid. It's going to really impact our decision about which to go with.
Yeah.
Are some of these, like the submucosal ones,
Yep.
is that both in and outside of
It
the
can
uterus?
be. It can be. Well, it can be in the endometrium. This is the endometrial lining.
Okay, so that's what you shed every month.
Yes.
Okay.
So it can be both within the endometrial lining and in the myometrium,
Which is
the muscle layer of the uterus,
okay.
which you cannot see when you look in with the camera. All you can see is what's within this cavity, that triangle.
Okay, so then when you talk about going in with the camera and cutting something, like that top one,
You're shaving, you can cut this one, you can cut that one.
but only part of that.
Right, exactly.
And that's what's going to keep pushing.
Potentially. Yeah.
Yeah, this is like the basic one. There's different types. There's phagotyping, and that's like type 1 means the whole fibroid, or type 0, the whole fibroid's in the cavity. Type 1, 90% is in the cavity. Type 2, 50%, and then 4, 5, 6. More it's going into the muscle than pushing out to the outer part of the uterus. So depending on, we can further type this even further down to see exactly which procedure would be best for you.
So if we see something that's like T1, T2 in our MRI results,
Oh, that's different. That's T1,
No.
T. That's the type of imaging, like the weighted part of the image. But for this, so for the type 2, so you're seeing that fibroid that's 50% in the cavity and 50% in the myometrium. There are times if you did one, say you were a patient that has 2 centimeter fibroid that's type 2, so 50% in the cavity, some in the myometrium. You could do that hysteroscopically. You may need to do a staged procedure, meaning you get 2, sometimes even 3 hysteroscopies to remove the whole fibroid. Sometimes it can be done in one, but in some cases you may need to do a staged procedure, but that would, you don't need to do an abdominal surgery for that. So exactly, we have to figure out which is going to be the best, we kind of figure out what's the best plan for you and what your goals are to figure out which surgery is best or approach is best. Maybe it might be doing nothing as well, just figuring out what individualized your care.
If multiple hysteroscopies need to be completed to remove the fibroid, how long should a patient wait in between each procedure?
So that could be usually about, I would say a month, 3 weeks to 4 weeks before that. And doing the hysteroscopic procedure would also, if you do, say, an abdominal myomectomy or even robotic laparoscopic myomectomies, patients that undergo those procedures, depending on how much you cut into the uterus, you may need a cesarean section at the time of delivery. So that might be something that you're thinking, like, I don't want to have a cesarean section, or I want to have the ability to have a vaginal birth. Then hysteroscopy is, the best way to go for that patient. But say someone who wants to have the procedure done as quickly as possible and move on with their fertility treatments, then that may be doing abdominal or robotic or laparoscopic myomectomy. So kind of have to figure out what's your plan.
And the other thing that I will just add to that is there are a combination of therapies, and I'm a big believer in combination of therapies, and I think sometimes we achieve the best results when we combine things to help you achieve the best outcome. So, for example, maybe this fibroid is really big, maybe we want to shrink the fibroid a little bit first and then go in hysteroscopically and remove it. Or maybe we want to shrink the fibroid a little bit first and then go in and use the Sonata device to ablate it. And I think I really like thinking about combinational therapy and individual plans because I think it helps you achieve the best results so we can minimize the need for multiple other procedures with anesthesia. So, and the LIFE program is also about that, preventing recurrence. So it's all about using these tools to best help you achieve best outcomes. Yes?
I have a few questions about the MRI. Clearly a little nervous about it. How long is it? Can you go in first? And then after you get your MRI results, do we then discuss a plan with you?
Dr. Chan, you want to answer?
Yeah. So the MRI, depending on the protocol, can take sometimes up to like 45 minutes to an hour. You are in kind of a large tube that makes a lot of sound. Generally, the radiologists are really good about like playing some music and making sure that you unfortunately can't bring in your own like AirPods or earphones to help you relax, but it is a little bit anxiety inducing in terms of actually getting the MRI. And then in terms of results, we actually take the time as surgeons to really open up the images and look at every single fibroid to see where they're located. And so everyone varies a little bit in terms of their practice, but in terms of follow-up of imaging, I usually like to have patients come in so that we can look at the MRI together and see where the uterus is in relation to their belly button, see where certain fibroids are located and what are the ones that are going to be causing you your symptoms. And so it really, I like to involve the patients and at least my patients in looking at the images together so it makes sense, because you're going to see it in your my chart and you're going to scroll through and you're going to be like, I don't know what I'm looking at, but it says like I have this many fibroids and they're enhancing or they're degenerating, and like what does that all mean? So, you know, bear with us. We are looking at your images, we're looking at your results, we're taking really the time to like make sure that we come up with a plan that works for your goals. Yeah.
Did that answer everything?
Yeah.
Okay, good. Yes. The risks of the procedures, yes. Yeah, I mean, in medicine we talk a lot about, risk versus benefit, right? And every procedure we do has a set of risks. The procedures, it would probably depend on which one, but most of them have the risk of infection, bleeding, and depending on how, like if we go in abdominally, for example, you do have the risk of injury to other structures in the abdomen, bladder, bowel, there's lots of things in the abdomen. But in general, the risks are very low, honestly. I would put it at like 0.3 to 0.5%. And, for all of us up here, we're experienced, in these procedures. But there are always some risks. And they also depend on your own personal history. Have you had prior surgery? Is there already a lot of scar tissue in the pelvis? What is your individual circumstance going in? But is there one in particular you were wondering about?
No, just in general.
Just in general. Yeah, everything we do has some. But the procedures probably have a little bit less than major surgery, but they all have they're all pretty low risk. Yeah.
So I have a question on the probability of recurrence, and I know that can be up to 7% even if you take out fibroid, and that's throughout your childhood years. But is that probability higher when you do get pregnant throughout pregnancy, like during multiple pregnancies, or does it kind of stay that probability throughout?
Dr. Castle?
That's such a tricky question and such a common one that everyone asks. It's tricky because we all know from treating patients with fibroids that there's such a vast difference. There's clearly so much we still don't know about fibroids in that, we'll see somebody who kind of just grows one big fibroid, their whole reproductive life, and we remove it and that's it, and they never have another fibroid again. Versus we'll have another patient who we go in to do a myomectomy, and I mean, I've removed up to 100 fibroids in like an abdominal myomectomy procedure for them. And they quickly have small fibroids growing back in the years afterwards. So those are two clearly very different fibroid pictures. There's probably something that we just don't know about how they're growing from one person to the other. We kind of went through a lot of the risk factors. Fibroids can grow in pregnancy. They can also what's called degenerate, which means sometimes based off of how the blood supply is kind of rerouting to the uterus and placenta during pregnancy, some of that blood supply can be taken away from a fibroid, and so it can undergo kind of a degeneration process because it's not getting enough blood supply. So some women can wind up with pain during their pregnancy as a result. Typically, I would say there's just a lot of variation in terms of how patients kind of come out of a pregnancy if they kind of go into it with a fibroid. So I would normally just kind of see what your periods are doing, after giving birth, and kind of deciding if, treatments are warranted based off of that. Does that kind of answer your question?
It does. I have a follow-up.
Yeah.
Actually, two follow-ups.
Yeah.
So one, once a fibroid is degenerated, does that happen once or does it degenerate multiple times?
That's a good question. I think in general, at least from what I've seen, I don't think any of this are hard and fast rules, but if we kind of see a fibroid undergo degeneration naturally, it often will have certain characteristics on imaging that we can kind of see in MRIs and things, and we typically don't see those fibroids grow too much afterwards. Again, that's not a firm rule. Of course, you know, I'm sure we've all seen a patient where it's degenerated and it grows a few centimeters in the following year, but typically that kind of means it's lost whatever its main blood supply was. They can be tricky though and find alternative sources, I would say.
And then the second one is there an optimal time to get pregnant post like a myomectomy or any one of these procedures, but primarily like a myomectomy?
Myomectomy, yeah. So, you know, you're going to see a little bit of a difference like surgeon to surgeon. In general, we quote trying to wait about 3 to 6 months after a myomectomy procedure to get pregnant. The idea is we want those incisions on your uterus to heal well. We want your uterus to kind of go into pregnancy from a healthy perspective. In general, if you're a younger patient, ideal to wait closer to 6 months. I've seen some surgeons kind of drop that recommendation down a little closer to 3 months. If you're somebody who's kind of maybe in the 35 to over 40 range trying to conceive, we know that person is also now battling some age-related fertility decline, and so we don't want them waiting too long after the procedure from that standpoint.
It's really interesting because there's so much variation in aggressiveness of fibroid disease, which is, again, one of these things that I think is really interesting and needs a lot more research. Like, why does one patient have one fibroid? We remove the fibroid, they never have another fibroid. But yet the next person has 60 fibroids, 100 fibroids, and they will recur again. I mean, I pretty much will say, unfortunately, we can remove all of them, but they will come back, like probably at about the 5-year mark, just on average, based on what I've seen. So it very much is kind of weighing these things and figuring out, for you, what's the best next step. But, a person who has one fibroid has a 30% chance of recurrence. It's more at that level. And a person who has 50 has like a 70% chance of recurrence. So there's always a scale. It's never like, one number for everybody.
In terms of these tricky fibroid questions when it comes to fertility, I think that's where, just getting really good imaging and sitting down with someone like one of us, a fibroid surgeon, and then potentially also like a reproductive endocrinologist, because there is a gray zone. There's some fibroids that very clearly need to be removed prior to pregnancy, and there's some fibroids that clearly aren't going to probably pose a major issue in terms of pregnancy, and then there's a big gray zone in the middle, and so kind of that's where we can hopefully come in, and with some high quality imaging, just in reviewing a patient's goals, we can kind of help you feel more confident in whatever your decision is.
Yeah, and we should say not every fibroid, and I think you did just say this, Dr. Kossel, not every fibroid has to come out, even for pregnancy. If you have small fibroids, if they're not in the cavity, if they're kind of on the outside of the uterus, we maybe don't need to remove those. They could stay. They might grow a little bit, but they probably won't, be an issue during pregnancy. Think about all the millions of women in the world who've gotten pregnant with fibroids. They didn't even know they had them, right? So it does really help us understand that, they don't necessarily have to come out. It is specific to each person. Their goals, the number, where they're located, that kind of thing. Yeah. All right, yeah. There's so more. I was going to say we could mingle and chat or eat or whatever form. I don't want to make everyone sit if people want to move around, but there's a few more questions, so. Okay.
So I'm trying to wrap my head around the shrinkage as a treatment, which just feels a little like you just want the whole thing out. Right? But so in your experience, is shrinking the minimally invasive options that mean that it's going to shrink? The benefit of that is that you have you're not doing the riskier procedure.
Yeah.
Well, again, it depends on the size and the location. So if it's going to be a big surgery to get to that location, right, then it makes more sense to approach it, let's say vaginally, through a transcervical fibroid ablation device like Sonata, because it's easier to get to it. It's right there, and the fibroid is not so huge. So we weigh sort of the intricacies of that, right? Like if it's in a trickier location, it probably does make sense to ablate. It might not be 100%. That is your drawback. It's not 100%.
I think every patient is so different. I mean, the way you just said it, we were like, I just want it out, So there's going to be a patient who's going to come to our office and say, I just want this thing out. There's going to be someone else who comes to my office saying, I have these bleeding symptoms. It is bothering me, but like I can't take a couple weeks off of work, or I'm really busy right now. I don't have the time to deal with this. And so, for that person, maybe that's where the Sonata comes in, and we can get it, hopefully shrunk down enough that we resolve their symptoms, and they didn't have to undergo, even our minimally invasive surgeries. They are surgeries, so they need recovery time, and so that's just exactly how you described it. Every patient's going to come in with a totally different perspective in terms of, I absolutely want to avoid surgery, or I absolutely want this fibroid out.
I think there were some more. Yeah.
Yeah, I had a question about something that came up during my appointment was like significant blood loss during the myomectomy. Is there anything like we can do to prepare for that? Like, I don't know, diet or just prepare our body to make blood?
I mean, we do preoperative testing. So if you come to our practices, you usually do a CBC. We're going to check your hemoglobin and see where that's at. And if it's at a lower state, sometimes we offer even oral iron infusions. So we have an infusion center at NYU where we preoperatively increase your iron, which is a building block for hemoglobin. So we can build your hemoglobin up from a very low level in even 2 to 3 weeks and be up to pretty much normal level to decrease your risk for getting a blood transfusion and things like that. We can use medications during the surgery to minimize blood loss. Depending if there's medications that help to constrict the arteries. We can put tourniquets or devices around the uterine arteries for a temporary time to reduce blood flow. So there are lots of different things we can try to minimize your blood loss. Depending on the approach, things like that can minimize blood loss too. Yeah.
Yes.
Just a couple more questions.
Don't feel bad.
Love questions.
One is on probability and one is on the life program. So kind of as a piggyback off of the blood loss question, I guess what is the probability of an open myomectomy, for example, turning into an emergency hysterectomy? Do you see that often?
Very, very rare. Most times, since we have surgically planned your surgery, where we've looked at the fibroids, we looked at the locations, it's very, very rare occurrence. Because if there was a fibroid, say that was coming into the uterine artery, which would be a very, very more dangerous fibroid to take, we may say, we're going to leave that fibroid behind and reduce your risk for requiring a hysterectomy, something like that. So there are things we can do to kind of minimize that risk. And maybe that we leave a fibroid behind just to ensure that more safety for you. But certainly there are patients, we have different risks for each patient. So say someone who's done with childbearing and they're like, listen, I want all my fibroids removed, but I'd like to still do a myomectomy. Well, maybe we go after that fibroid and still have a little greater risk for a hysterectomy rather than someone who is desiring future fertility. We may say, we're going to go the safer route on this patient and make sure she maintains her uterus. So in my practice, I haven't had to do that, but I'm sure someone's had that unfortunate case, which is always a risk for major myomectomies. Would you guys say the same?
Yeah, I agree. I mean, it's very dependent on where you're kind of getting a myomectomy, but in terms of major blood loss, like need for a blood transfusion, I mean, if you look at the literature, there's some studies that quote super high rates of transfusion. I think in hospitals that I've worked in, approximate transfusion risk with a myomectomy around 5%. Things that can definitely escalate that risk much higher are if this is a repeat myomectomy surgery. So that's something I counsel patients on. If this is your second or your third myomectomy surgery, the chance of you needing a transfusion is getting higher and higher. If you otherwise have endometriosis or any other conditions that would have created scar tissue in the pelvis that we have to then kind of be working around that scar tissue, it's going to increase risk of bleeding. Our center, we utilize like something called Cell Saver in big myomectomy surgeries where we can actually collect some of the blood that's lost and potentially give it back to the patient. So that's helpful.
Was there one more part?
Yes.
Oh, you thought so.
And my last question is on what catalyzed the LIFE program?
Oh, yes.
And then if you can just delve into like what levers are you pulling to kind of verify your hypothesis or anything like that? And I know you mentioned diet, exercise, and supplements, but if there's anything else that you didn't mention.
Yeah. Shok, do you want to talk about the LIFE program? I mean, I'm happy to say the last part of it, but maybe you want to talk a little bit about.
Yes, sure. So, we do know a lot about uterine myomas or fibroids, but there's also a lot of things that we don't know. Like Dr. Shirazian talked about, are there external factors that impact the recurrence of the fibroid, right? Because once we get this thing out, then we definitely don't want to have it come back again. And so the idea behind the LIFE program is that we are recruiting post-surgical women who have had one of these procedures, and if they meet certain criteria, we encourage them to join in this LIFE program, which includes kind of our dietary and lifestyle intervention recommendations that we've cultivated based on literature that we've seen. So it would involve a visit with me and follow up with me as the dietitian. So we talk about diet in terms of what's out there, what is the literature saying, what kind of food compounds, what kind of nutrients impact the recurrence of a fibroid, and what can we do with your diet, what can we do with supplements to reduce the recurrence of that. And then also lifestyle. Do we need to work and address weight management? Is there a weight issue as well? So all of those things are kind of included part of this. Again, we're still exploring this area of diet and lifestyle. So that's why we have this program, is that we're trying to understand more about it. If you follow this protocol, if you come and we talk about your diet and I go over your diet and we address some areas that need to be improved upon or supplements that you might need, which we mentioned a little bit earlier about vitamin D. There's also a little bit of literature about turmeric. So we kind of talk about that, implementing that, and follow you for about a year. And then we intermittently check in every 3 to 6 months, and we obtain labs. We will repeat, and I have you fill out a whole nutrition questionnaire so that we can assess and see here the relationship between dietary compounds and food in particular, and how that impacts uterine myoma or fibroid recurrence here pretty much. So we'll also be repeating and doing vaginal ultrasound as well to assess for that. So that's an option as part of the LIFE program, but even if you don't want to participate or you're not a candidate for that, if you just want it to be a part of what Dr. Shirazian talked about as active surveillance, then you can also meet with me, and I would be happy, of course, to share my knowledge or what we know so far about the dietary kind of aspect of managing this.
Did that answer your question? Yeah, I think, the program actually was created with a group of like 5 of us who really culled all of the evidence that's been published on diet, exercise, and supplements. And there is not a lot of great evidence. There's not. Which I wish I could say there's all this great evidence out there and there's like 10 things that really would help, but we don't really know exactly how well they will help. But there's some that have better evidence, like vitamin D. So we put them all into this program, anything that had decent level evidence, and we call it the LIFE program. And we're basically going to be collecting, lab parameters, looking at like CBC iron, vitamin D, glucose, all of the things that impact your health that also could contribute to fibroids, and then follow them over the course of the year. And it's a pretty new program. We've been doing it a few months. And we've been I've had discussions with patients, with others, about adding a few other things to the survey that we provide. So I'm going to start doing that. And that's going to include, like, I've been getting a lot of questions about hair relaxants, and do those contribute to fibroid growth? Because they contribute. There was a big article that came out saying that it contributes to uterine cancer. I don't know how many of you saw that. And it was actually a pretty good study, I thought. So, just maybe collecting data on use of other things, or experience or exposure to other things like that, so that potentially down the line we can draw some, associations. We'll see. But collecting more data. All right, yes. Last question, and then we'll mingle. You guys can still ask questions, but we'll just make it a little more free form.
So
Yeah.
is the LIFE program, am I saying it light or life?
Life.
Life.
It stands for a Lifestyle Intervention in Fibroid Elimination Program. So big claims.
Because I know that a lot of, what I've read is that fibroids is caused by stress. And is there a stress management that is in the program?
It's a good idea. You're actually the fourth person today, because I saw patients today, to mention stress to me and how stress contributes to fibroid growth. The problem with stress is, how do you measure stress? If anyone has an idea for me on that, I will take it, because I would like to measure it.
Just waking up in the morning could be stressful.
Right? It's so personal, it's so individual. What's stressful to you is not stressful to me. But I do think it's important. The measurement of stress is what's hard. And we have to be able to measure it to really be able to follow it or make claims about it. So that's what we think about in research. Like, how can we quantify this? How can we measure it so then we can follow it and see if it's changed? All right, well, let's grab some food and can just mingle if anyone has any other questions. We're here.
Also, if anyone would like to make an appointment with the Center for Fibroid Care, you can see one of the ladies at the front desk.
There's another event, right? I can mention that. It's called it's really interesting. It's called the White Dress Project. And it's actually a patient advocacy group for fibroids. And they're doing an event in Brooklyn in a few weeks. So it's a patient-specific group that I thought would also be interesting. Because a lot of people ask me, well, what about, we want to talk to other patients who've had experiences, who've had surgery. Yes. So that's why I think mingling is good, because there may be people in the room who've had whatever it is you're looking at. I can't really call them out. You can talk to Heather. Heather will tell you about her experience. She's had many, many things. So you can talk to Heather. She's willing to answer any question. Yes, I have known Heather forever. Love her. Love her. I know we are. We're pretty much the same age, too, so it's like. She started small. We've been fighting. We started big. We started with the first was the Maya. Okay. So.
Based on the question, if it really is location. It really is.
You're right. We started with the Maya, then it was the hysterectomy.
I had endometriosis, and I ended up having a 6-hour laparoscopic surgery that, when they discovered where the really big one was, like, they couldn't assess it, and then that's how I met Dr. Shirazian. But we needed to do it a year later because it needed to be full cut, because there were concerns with scar tissue, and I had to drive to work at that time, so I couldn't put on the seatbelt.
Yeah, she had surgery somewhere else first, so.
Was here.
Was it at NYU? Okay.
Yeah, it was in my, but
Yeah.
yeah, long ago.
And then she came to me, yeah.
And then that thing that caused, oh my God, the hernia, that fibroid, so for me, my fibroids are just wreaking havoc on my body. It caused a hernia, and then I needed hernia surgery 3 years later, and then 7 years after that, I had to just do the full Monty. I couldn't take it anymore because I was having spinal issues with the other fibroids that were being generated. But
So.
I'm happy.
So Heather's an amazing spokesperson. She also advocates. Yes, she advocates for women. And yeah, so she agreed to come tonight to support and answer any questions. So if anyone has questions about, procedures, she's had a few. And she can talk about endo too. We didn't talk about that, but, endometriosis can go along with fibroids. So we do see those things together in the same person, and that can complicate the surgery too. Did you want to say something?
I don't know if I should say fibroid, but I remember at one point in my life, before I was menopausal, I was bleeding extremely a lot, and the doctor at the time said that it's coming from my fibroids, but if they would give me some pills or something to stop my menopause, to get into menopause, that's possible to shrink. Do you have anything to comment about that? Which it did.
Yeah, it could have been, it depends on when it was done, but maybe if it was years ago, it could have been like, I'm thinking Lupron, but that's an injection. They gave you something oral.
Yeah,
Yeah.
I just want to make that comment.
It could be birth control pills. It could have stopped the bleeding with birth control pills. That actually was probably what it was. Yeah. So there are, lots of choices, and I think for each person there's some different choices that are good. But yeah, so if we want to mingle and talk and meet your neighbors, I think. Thank you.